talk about atherosclerotic vascular disease, sort of the conventional wisdom. Where are we today? What are the conventional approaches to this disease? And again, thank you very much for that nice introduction. The other aspect of what I do, besides being busy clinically, is I do a lot of basic science work. And my lab for many years has really focused on smooth muscle cell, endothelial cell biology, how it interacts with materials, but it's also very relevant to the issue of coronary artery disease. So I'm going to use that perspective in this talk. What I'd like to do over the next 45 minutes or an hour or so is go through a variety of topics. I'm going to speak quickly on some things and then I'll slow down on others. Maybe somebody can give me a glass of water also, be helpful. And what I'd like to do is cover first the epidemiology, talk a little bit about atherosclerotic pathobiology. It's sad that Andy Selwyn's not here, but I'll cover some of this. Talk about risk factors, both traditional and novel. Talk about prevention. And then an area that I've been involved in with inflammation and newer aspects, periodontal disease. I'll give you a little tidbit of some new things that we're working on towards the end. I don't have to tell this crowd, but I'll just reemphasize how important atherosclerotic disease truly is. It's responsible for a tremendous number of deaths around the world, about a third of deaths, 42% of deaths in the United States by some means. There are 70 million Americans that have one or more cardiovascular disease. That's really a quarter of the population. And if you look at the numbers, this is from the American Heart Association, about 13 million have coronary disease, cerebrovascular disease certainly with stroke is high, peripheral vascular disease, renal vascular disease, and on and on. So a significant problem for us from a health perspective. Number one killer in the United States. Here are some frightful numbers. One cardiovascular death every 34 seconds. The number of deaths from cardiovascular disease far outweighs all the traditional things that we always hear about as far as causes of death. Many patients die before they get to the hospital from cardiovascular disease. Now with that sort of somber first statement, we're making a lot of advances. Certainly the deaths from cardiovascular disease have risen, but then they've started to plateau with prevention and knowledge and everything that's going on in the medical world. But despite that, we have some new epidemics, things like this, where basically the obesity epidemic, the way we're eating in America, there are a lot of things that are driving yet a second wave of cardiovascular problems. If you look at the breakdown of cardiovascular disease and death, the bulk still remains coronary artery disease, which is truly mediated by atherosclerosis. And then in addition, cerebrovascular disease, and then other forms of disease, congestive heart failure, etc. Age is a risk factor. There's clearly a prevalence and an increasing prevalence of disease for both men and women as we age in the world. The interesting thing, which is the sad thing, and it's interesting that there's a winery specifically for women, while we've made great advances in reducing cardiovascular mortality for men, it's very sad as far as our effect for women. Unfortunately, the cardiovascular disease for women is frankly somewhat on the rise, and it's a more difficult disease to take care of. And this has hence been the reason why the American Heart Association has sponsored the Go Red campaign, where this is truly a major health problem that needs to be addressed. So let's talk about what are risk factors. What are the issues behind driving these diseases? Well, a risk factor is a variable or a feature of an individual or population which, if present, particularly early in life, may increase the risk of the disease. It typically correlates with the disease, but it may or may not be causal. It may not cause the disease, it may just be there as an associated factor. And we'll talk more about this. There are four basic categories in the literature. As you delve into this, it's a very interesting but somewhat confusing arena. There are predisposing factors, there are risk-modifying behaviors, there are metabolic risk factors, and then there are disease markers or biomarkers. So if we think about what we sort of know from our medical work on a daily basis, you could categorize these risk factors as follows. There are predisposing risk factors, which we can't really do very much about. Age, sex, your family history, your genes. You're stuck with that. There are risk-modifying behavior, things, smoking, the diet, your lifestyle, level of activity, alcohol intake, and of course they're meaning excessive alcohol intake, not the healthy alcohol intake we're partaking of here today. There are metabolic risk factors in terms of certainly the lipid hypothesis, and hyperlipidemia, hypertension, obesity, diabetes, and metabolic syndrome. And then there are other markers which people are looking at as whether they're causal or not, things that we're following, and we'll focus more on the inflammatory state as well. So think about risk factors as either modifiable or non-modifiable. And then we can also categorize them as both traditional and as new ones that are emerging. So the traditional risk factors I've listed here: age, male sex, smoking, hyperlipidemia, hypertension, diabetes, obesity, lack of activity, and certainly mental stress. And what are the goals of risk factor management? Certainly our goal is to improve survival, but we also want to reduce the likelihood of a recurrent event. We want to reduce the need for interventional procedures, which then drives healthcare costs. And certainly we want to overall improve our quality of life. This has been mulled over by many groups because there's cost behind this. The government has been involved, payers have been involved, American Heart Association, American College of Cardiology have looked at this, and they've categorized, and this continues to evolve, but I just thought I'd show this to you, the way we can approach risk factors. Factors which intervention has proven to lead to risk reduction. Clearly, stopping smoking, modifying your cholesterol, high-fat diet, reducing that, taking care of blood pressure or LVH. Then there are factors for which it will likely reduce risk. Certainly diabetes, although I think I'd throw this up on the top now, HDL cholesterol, inactivity, triglycerides. And then factors for which intervention might lower risk. Psychosocial issues, LPA, homocysteine, these are still debatable issues. And then there are unmodifiable factors, which we just discussed. It's also important to differentiate between a risk factor and a risk marker. A risk factor can predict the risk of the disease, it's associated with the disease, and it may or may not be causal or a contributor. A risk marker is typically like the same, but it really has no causal relationship. It may ride along with the disease and may provide insight as to the disease state and activity. But also know that some parameters may be both a risk factor and a risk marker. What we've learned from large population studies like Framingham and others is that as you start to add in risk factors, your risk tends to go up. This is a demonstration from Framingham that as you add the number of risk factors over 10 years, your risk continues to rise. And the same not only for coronary disease, but also for stroke. Multiple risk factors are additive, driving these diseases. This is from the NCEP, National Studies on Cholesterol Education and Prevention Studies, and they basically emphasize another important thing about risk factors. You think, well, you know, I may have one major risk factor, I have minor risk factors. Is it that important to treat the minor risk factors? What we learned from NCEP is that even if you have multiple risk factors, if you intervene on them just a little bit goes a long way. Modification of multiple risk factors, even slightly, has a major impact, maybe even greater than if you had just one major risk factor that you worked on. So it's important to really hit a lot of points. So therefore, it's important for us as physicians, healthcare providers, in the healthcare community to really assess the risk of that patient, to understand which are those points that we may be able to modify for that patient and thereby improve their health. That means a careful assessment of their medical history, physical exam and lab values, understanding their environmental and behavior history, tobacco, diet, physical activity, a very careful physical exam, seeing other modifiable risk factors, their obesity status, and really then using other instruments which can determine the global risk score, particularly things like from Framingham, the 10-year risk assessment for coronary artery disease. This is the Framingham risk scoring system. I don't know how many of you use this, but this is a very helpful tool. It's evolved as a continuous model versus a categorical model to give you a 10-year risk prediction. They've since developed a 30-year risk prediction as well, because the Framingham study has been going on for a long time, but it's pretty easy to use. You basically assign yourself points. And you actually can do this. I've done it for myself. You look at your age. You then look at your cholesterol or your LDL or your total cholesterol. You look at your HDL. You look at your blood pressure, and you add the diabetes, etc. You add this up, and it basically you can look at what your risk profile is. And this has been devised from tremendous population studies. Now, this has also been validated for both white men and women and black men and women in the United States. And subsequent studies, this is from JAMA, have shown that this could be applied to other ethnic groups with minor recalibration. So it's valid in these groups as well. But still, efforts are going on to develop sharper instruments. Paul Ritker published this paper on the Reynolds risk score, which is yet another enhanced modification. And again, the statistics behind these are pretty heavy. You have to take a lot of time to kind of go through these. What about a biomarker? So a biomarker is really a characteristic that is objectively measured, an indicator of normal biological processes, pathogenic processes, or pharmacologic responses to an intervention. Now, there are criteria that have been established for the efficacy of a biomarker. It has to be associated with the outcome of interest and should be statistically significant. The marker should improve your risk prediction. And of course, any new marker that pops up has to be easy to do, cost-effective, safe, acceptable, to have the appropriate reagents, and ultimately somebody's going to have to reimburse this. But this is a big area of work, developing new biomarkers as well. I'm not going to go through the long laundry list, but there are many new markers, and they all come from understanding the pathogenesis of atherosclerosis. But interestingly, even elevated white count now has been demonstrated to be yet another marker of accelerated atherosclerosis as well. Now, what we learned, though, is from Framingham, this is recently published, is that if you add in multiple markers, they can only marginally, the current ones we have today, that doesn't mean we shouldn't continue our work in this area, but they still only marginally enhance our ability to classify risk. So really, what I'm saying to slow down is if you go back to the traditional risk factors and understand them and use them, you've pretty much covered 99% of the issue, and if you added one or two things new, that'll be helpful as well. Let's spend some time understanding now the pathobiology of atherosclerosis. This is really a progressive disease that can hit large arteries, really having to do with lipid and fibrous and cellular elements in the arterial wall. We used to think of it as an intimal disease. We now know it really involves all elements of the arterial wall, not just the intima going across into the media and the adventitia as well. This is a schema of the vascular tree, and we know, shown in red, that there are hot spots, particularly where atherosclerosis is involved. Certainly the coronaries in the heart, certainly the cerebrovascular circulation, the carotid, the large vessels like the aorta, renal vessels as well, and then the peripheral vessels, the iliac and femoral system as well. But still, atherosclerosis can occur anywhere. But typically, each zone has each type of disease. You have an infarct if it's in the heart, a stroke in the brain, gangrene in the foot, or an aneurysm in the aorta, or renovascular hypertension in the renal arteries. Now, really, atherosclerosis, though, if you really study the pathobiology, is this is a very diffuse disease. It's a hot spot on top of diffuse disease. So this is the complete coronary tree of a patient who died. He ultimately died because he had one super tight lesion, but if you look at it, he had disease all throughout his coronary tree. So we really have to develop methods of really modifying this in an early stage. There are many historical mechanisms that have been developed behind the pathogenesis of atherosclerosis. Certainly the lipid hypothesis still reigns supreme. The classic paradigm as far as atherosclerotic development is that multiple types of risk factors and other exposures and genetics led to an impairment. The first thing is an impairment of endothelial function, which then leads to an influx of LDL and other moieties, which can then become inflammatory, which can then lead to an inadequate wound healing response and ultimately some type of on-off thrombosis and ultimately a plaque. But this starts when we are born, and this is the important point about risk factors and understanding this. This is a fatty streak which happens, this is from an unfortunate child who passed away for another reason. Looking at the arteries, you see there's an early fatty streak, and this is due to the incidation of these large lipid. The larger the lipid particle, the more atherogenic it tends to be. And there are multiple receptors on the endothelial surface which lead to these moieties going inside of the blood vessel wall. Here you can see some of these in the cartoon going inside. This is the inside of the artery. And this is not just a cartoon. This is the actual work. This is from Russell Ross, famous atherosclerotic biologist. He passed away a few years ago, showing you these types of particles now in the wall of the artery causing havoc. And when they build up, the artery responds to this and essentially forms a mini organ where smooth muscle cells cordon this off, attempting to create a barrier. The endothelium is deranged. Inflammatory cells come in, and you're off to the races with an atherosclerotic plaque that's forming. We've also learned that the body keeps these and can accommodate these over a long period of time. This is Seymour Glaga from Chicago, showed that basically your arteries continues to grow despite the fact that you have atherosclerosis and there's no blockage. Up until 40% of the cross-sectional area is filled with atheroma, and then it's too much for the artery to continue to enlarge, and then you start to develop a stenosis. We can only detect stenoses down here due to physiologic tests. But all this has been going on for years, and that's the point about risk factor assessment early. And healthy lifestyles ultimately is the point to modify this at the end. Now, atherosclerosis exists in a lot of flavors. This is a conventional plaque. This is the artery. This is the lumen where blood flows. And this is the atheroma, which is fibrous and fatty. But it can also be muscular, and it could also be calcified. And this shows in a calcific lesion as well. So if you slow down for a minute and think about this, you know, the beauty of having been asked to give a talk is it also forces you to go back and think about this on your own quietly. And I sort of put this slide together, which is that if you think about risk reduction and conventional strategies, we have a real task. It almost starts before the patient is conceived. From a genetic perspective, and environmental exposures are additive. Then in utero, we now know that for a pregnant mother, high levels of lipid and smoking, etc., can also drive early atherosclerotic lesions. This is new biology. Then on top of that, in infancy, and with now a lack of exercise and the obesity epidemic coming along, and then teenagers. I'm dealing with teenagers myself, my own 2 daughters. So you have to deal with the novel risk behaviors that they may then entertain. And then beyond this, all the issues that we face as traditional adults, these all add up to lead to a high risk profile. The traditional approach to prevention from the American Heart Association and others was to look at these as disparate groups. The future is really to start to integrate that concept and now to specifically target novel risk factors and other things in individual groups to attempt to reduce the risk much earlier. So I actually propose, this is just for fun, that maybe compared to the way we now look at heart failure, we might actually look at atherosclerosis this way. This is my sort of suggested classification, that we have stage A is where you have a risk propensity for disease. Stage B is where we have the propensity plus early pathology. C is the actual disease. This is like the New York Heart Association classes 1 through 3 of angina. And then 4 is when it's really you're in trouble and we really need to do an intervention. So let's run through the conventional risk factors that we have. Hyperlipidemia, LDL cholesterol. It really fills the classic, like an infectious disease, the modified Cox postulates, where high levels of cholesterol predict disease. Animal studies have demonstrated it causes disease. The biology supports it. There are LDL receptor mutations which support this. And certainly if you drop lipids, it certainly reduces clinical events, just like treating an infection. Mainstay of therapy has been statins. They, through HMG-CoA reductase modification and inhibition, block this pathway which ultimately forms cholesterol in the body. Tons of studies. On this slide, 90,000 participants in 14 randomized trials all show whatever you look at, non-fatal MI, any cardiovascular event, coronary revascularization, stroke, always better when you're treated with a statin. Primary prevention trials, WASCAPs, ASCAPs, TEXCAPs studies also looked at all the endpoint variables. Always some type of reduction in cardiovascular mortality, total mortality, cardiac death, non-fatal MI, etc. Better with a statin. Secondary prevention. That means you've already had the problem. Now we want to prevent the recurrence of a problem. Multiple studies, 4S, CARE, lipid, etc., all show with treatment a generalized reduction compared to placebo in events. Big groups behind getting the message out. So this is the NCEP, National Cholesterol Education Program. They have the adult treatment panel, published a report in 2002. And then 5 new studies came out, which then led to a modification and further change of the risk classifications to treat to new targets. Those are the buzzwords. And what happened here is when you put all the studies on a slide and you look at progressive reduction in LDL versus event rate, you see you get this kind of linear relationship which tells you lower is better. Now you need some cholesterol because every cell membrane has cholesterol in it. But basically, the old targets that we had of a 150, 130, 100, we're pushing it down to lower and lower. Really the number here, magic number, is kind of 70 and below. But you should know this, the concept of high risk based on the Framingham concept. High risk, coronary heart disease, risk equivalence, and a 10-year risk greater than 20%. Moderately high risk is 2+ risk factors, and a 10-year risk of 10 to 20%, and the others lower as shown on the slide. And really the new ATP3 modified guidelines are really the concept of, if you can, to get to an LDL cholesterol less than 70. That's really where you should go. Now certainly they say this is really for high-risk patients, but I really personally believe, this is my 2 cents on it, that we should really go to a lower cholesterol if possible. And certainly There are other aspects to the cholesterol story as well. That is, even if you have a good overall cholesterol, if your HDL is unfortunately low, as your HDL is unfortunately lower, your risk goes up. Now, we have very few ways of raising HDL today, and I will tell you that drinking some wine is certainly a very helpful way to raise HDL, along with intense exercise and taking niacin. Lp(a), I threw this in just for completeness. This has been an interesting factor that people have looked at, but frankly, you can't do much about this, and really the only thing to modify here is use high-dose niacin. I want to quickly go through a little bit about inflammation. What I've talked to you first about is the concept of the traditional pathogenesis of atherosclerosis, which is lipid-based. The new biology, which has really bubbled up over the last 8 to 10 years, is the concept of an inflammatory paradigm. It's not only lipids. So this is the traditional approach: artery, lipid, streak, plaque. The new approach is that other inflammatory mediators and an inflammatory milieu in the body, whether it's infection, whether it's chronic inflammatory disease, whether it's various exposures, smoking, etc., lead to other endothelial changes, which then leads to an immune response and a parallel inflammatory response, which are different, which then leads to a lot of these inflammatory cytokines, which then goes back over here along with lipids and drives the process. Now, what's the data? Here are arteries early on, and you can see they express these adhesion molecules, even in a fatty streak. VCAM, which is involved in attaching monocytes. ICAM, involving in attaching lymphocytes. CD68, involved in attaching macrophages. This is what happens. Macrophages, monocytes in the blood, rather, are rolling by. The cell becomes damaged. It expresses an adhesion molecule, and it starts to tether. Rather than floating quickly, it slows down and rolls. Then it adheres quickly, tighter, based on new adhesion molecules, and then it moves through the artery wall. To give you an idea, this is very real. This is an actual scanning EM from an artery in an animal model showing you how this moves across the vessel wall. You can see how a white cell can crawl through the artery wall, raising havoc. That's a scary picture. Now, wine may modify that, so drink a little. I suggest you have a little wine right now. Because this is a long talk, so you need to temper what I'm saying here. But here you can see the white cell, and it's crawling through. And again, I took this picture. I did not do this cartoon, but this is very similar to what's actually going on. And then inside the vessel wall, all the lipid is there, and then the macrophage eats this and becomes what's called a foam cell. I didn't take this. This is from Russell Ross. But it shows you, again, what happens. These are these foamy macrophages inside the vessel wall. So what happens with these foamy cells? Well, they then send out all these inflammatory mediators, interleukin-6, fat cells, and this is if you're obese as well. Interleukin-6 goes to the liver. Liver sends out prothrombogenic and other inflammatory mediators, which then go back and drive this process. So what's going on is, this is the traditional hypothesis, but the new hypothesis is that this inflammatory accelerator drives everything, leading to worsening atherosclerosis, potential plaque rupture, and thrombosis as well. So how can you modify this? Well, statins. The beauty of statins is that not only did they drop lipids, but statins have what we call pleiotropic effects. That means they modify many other things, and the beauty of statins is they're tremendous anti-inflammatory compounds. So statins actually inhibit white cell binding to endothelial cells. Statins reduce the production of interleukin-6 in fat cells. Statins have a direct anti-inflammatory effect just directly, and this is in an experimental inflammatory model. So how does C-reactive protein fit into this? And again, I know I'm treading on controversial water, but let's talk about it. This is a very interesting biomarker, or maybe it's a mediator. It's a pentameric polypeptide. For those cell biology buffs, it's called a pentraxin. And it's been shown to be associated with cardiovascular disease. This is from Paul Ridker, who's really made his career based on this. And what he's demonstrated, as you add in some of these new biomarkers, if you add in the total cholesterol divided by HDL ratio and CRP, this is one of the highest predictors of relative risk of acute myocardial infarction. And this shows you the additive benefit. You look at one risk factor, another, you add them two together, things look better. Despite the fact that what I showed you earlier, not all risk factors provide an additive benefit, but this seems to be working pretty well. So this is actually from the Frisk study. This is a study of acute coronary syndrome, but it shows you as that CRP levels start to go up, your risk of having probability of death goes up. Again, a pretty strong statement. So is this a mediator or is it just a marker? Well, this is from experimental cell work on endothelial cells. It shows that C-reactive protein leads to a dose-dependent increase in macrophage chemotactic protein involved in the process of atherosclerosis, and statins will block this. In our laboratory, we've presented at the American Heart Association showing you that C-reactive protein leads to more smooth muscle cell migration and proliferation, which drives the plaque. So the Jupiter trial is one of the most recent studies, which actually looked at 17,000 patients that all had fairly good cholesterol. This was an old target, and they were on a statin, and they were randomized to either rosuvastatin or placebo. And what they showed is clearly patients that were on the statin had lower primary endpoints of death, MI, stroke, or any vascular problem. And here's MI broken out as well. But the interesting thing, this is really what shook everybody up, was that, sure, cholesterol was under control, but over time, over a 4-year period, if you look here, cholesterol here, didn't really change. It was already nicely down. But what did change is that CRP went down, and continued to drop over time if you were on the treatment group. So here you see it continue to drop. So that's an important point. So they raised the issue, does treating CRP really make a difference? And I will tell you that in the current issue of JAMA, I didn't want to confuse everybody, but you have to read the current issue of JAMA because there's a paper, it's a very interesting genetic analysis, which looked at whether or not C-reactive protein truly has an impact on the disease. From a genetic argument, they're saying maybe not. But there are a lot of flaws still with that type of genetic studies. So I encourage you to read that. It's very, very interesting genetics in that paper. What I will tell you is that on a positive basis, we know that alcohol consumption certainly will drop CRP. So I'm still a believer that CRP is involved in pathogenesis as well as a marker. The good news is having a little bit of wine here, basically 1 to 2 glasses a day, will certainly drop your CRP. So that's a good thing. So we've talked about the traditional risk factors. Let me zoom ahead and talk about some of the other risk factors. I'm not going to cover these as extensively, but I will tell you that as far as behavior, smoking is one of the single most important risk factors for coronary disease, tremendous preventable cause of death in the United States, more than 500,000 deaths per year, and about 40% of these are due to cardiovascular death within this group, and 8% of these are due to secondhand smoke. So just being in the room is a big problem. The sad issue is that tobacco use, despite all the campaigns, is actually increasing in a sad group, our young adults, and in women who have a problem with atherosclerosis to begin with. You don't have to go through this long laundry list. I just want to tell you that smoking drives atherothrombotic events. It elevates your blood pressure. This then changes oxygen demand and oxygen supply. It leads to oxidation of LDL. It changes endothelial function. It drives inflammation. And all the things that we alluded to before. And certainly the risk is also enhanced if you're on birth control pills for women. 20 studies, meta-analyses from a recent JAMA, show you that if you can you will definitely reduce your risk of coronary events if you stop smoking. So that, I think, is very, very important. Smoking cessation on average would reduce cardiovascular mortality by 36%. Very important. Let's turn to hypertension. Another significant risk factor. 50 million Americans have hypertension. There have been multiple studies looking at the demographics of this. We know there's a joint contribution of systolic and diastolic hypertension to risk, though systolic may have a little bit more impact. And as we age, that becomes more of an issue. We now understand the concept of continuum of risk. It's not just 130/90. There's a continuous spectrum of this. It's not just a dichotomous variable. This is just to demonstrate for you from the health and nutrition survey studies that as we age, independent systolic hypertension becomes more of the issue, as opposed to when we're younger, diastolic hypertension is more of the issue. They both contribute to cardiovascular events. I don't know what happened there. What you see is diastolic has some contribution, but systolic tends to have a greater contribution. This is from the Mr. Fitz study, a study of a few years ago. The big point, and what I alluded to earlier, is that you just need a little bit and it'll make a big difference. Blood pressure reduction as small as 4 to 5 millimeters of mercury will result in a large reduction of risk of MI. There are many ways to do this, certainly salt restriction, more calcium and potassium in foods, weight loss, and more physical activity, and then drugs. Certainly the JNC7, which is a little dated, JNC8 should be coming out, 42 trials, showed a 21% reduction in coronary artery disease with some therapy. It really doesn't matter what, although there have been the traditional JNC has talked now about use of a diuretic as a first-line therapy. It's very interesting. When I started as an intern, it was JNC2 and diuretic was the vogue. We've gone through the full cycle. Now diuretic is still the vogue. We've come back after trying many other drugs. How about diabetes? Diabetes is a problem. It's a growing problem, no pun intended, because of obesity epidemic in America. Having diabetes is really equivalent to having a risk of aging 15 years. That's really a bad sentence. The impact of diabetes is increasing. It's even greater, I think, now than smoking. And it's interesting to read various articles about this because one sort of competes, and it's difficult to tease that out. But I really feel diabetes is a big driver from a biology perspective. You have a 2 to 8-fold increased risk of coronary artery disease. 35 million Americans have abnormal glucose tolerance, and even more have a sort of early pre-diabetic state. The Nurses' Health Study, which is an interesting study, showed that of those patients who eventually developed diabetes, they had 3 times the risk of having an MI before the diabetes was even diagnosed. So that early pre-diabetic state was a real driver of cardiovascular disease. We now know, this is from the ACES registry, which has demonstrated, and many other studies as well, that if you have diabetes without coronary artery disease, it's now a risk equivalent to having early coronary artery disease. There you go. No diabetes versus diabetes and no cardiovascular disease. So that's a really big statement for the American Heart Association to actually adopt the concept of diabetes being equivalent, if you will, to coronary artery disease. What does diabetes do? It certainly drives the pro-inflammatory state. It leads to endothelial dysfunction. You modify many proteins with sugar, which then leads to derangement of function at a cellular and biochemical level, drives coagulant state, etc., and leads to diabetic nephropathy, which also then drives atherosclerosis as well. A lot of detail, not as important. Just know diabetes is a big risk factor. And associated with diabetes is this entity, which is either real or not, depending on if you like to believe it, of the metabolic syndrome, which has many different definitions from different groups. A basic central obesity, high triglycerides, a low HDL, hypertension, and insulin resistance. And the more the number of factors you have, the greater the risk of developing cardiovascular disease. This is from a study which basically looked at coronary mortality, and it showed that with the NCEP definition, clearly with obesity and with metabolic syndrome, you clearly had an increased risk. So again, something that needs to be treated in our patient group. Now, how about the intensity of treatment? Again, this is an important point about the intensity of treatment, and there's some controversy here. This is work with type 1 diabetics, not what we're really talking about. We're talking about type 2 diabetics. But in this study, they showed if they used intensive therapy, their risk of ultimately having cardiovascular abnormalities was significantly reduced, death, MI, and need for vascularization. That's the juvenile diabetic. For the adult onset diabetic, the obesity-associated diabetic, the type 2 diabetic, what we similarly see is that there's a reduction. This is from the UK PDS studies. A large series of studies show that you reduce risk if you treat diabetes as well. So you would think that, well, maybe stronger therapy is better. This is where the controversy comes in. This is fairly new, looking at ACCORD, ADVANCE, and the VA diabetes trials. What they actually showed is that intense diabetic therapy, where the goal of a hemoglobin A1C less than 6 as a target, was actually, the enemy of good is better here. It was not a very good thing. Severe hypoglycemia actually occurred, and this might actually increase the risk of cardiovascular deaths. In both of these studies, no benefit was seen in cardiovascular outcomes for intense therapy, and there was actually increased mortality in the ACCORD study, saying you got to be careful if you're really going to hammer this intense therapy strategy. So that's sort of the take-home message. You just need good control, but not overdo it as far as control. How about obesity? Obesity also is a big driver. Increasing your BMI is associated with increasing risk factors and risk markers across the board. CRP is up, LDL is up, ApoB is up, LP little a is up. They're all up as you become more, and as your BMI goes up. So a big problem as well. And the therapy for this clearly is exercise. Exercise has a tremendous benefit. Conditioning and training effect reduces myocardial oxygen demand, it enhances your endurance, it reduces obesity, it has an impact on blood pressure and on lipids, it reduces inflammation, it reduces your prothrombotic state, and it enhances endothelial function. So these are all good things. How about the intensity of this? This is a study looking at exercise in women because people are still averse in America to big-time exercise. The bottom line is a little bit is good too. This is a walking study, and it showed that just a little bit of walking reduced your relative risk of cardiovascular disease. But certainly, this is one place where stronger is better. The more intense the exercise, this is in the Harvard alumni study, what they actually showed is that if you exercise harder and harder, this is cardiovascular exercise, not isometric exercise, aerobic exercise, the more you do, the better off it is. And it really starts to exponentially go up if you go way up in your activity level. And certainly stress, depression, and other psychosocial issues still have an impact, and there are other factors. The debate exists in this domain. Should you use drugs in treating these as well? So I want to kind of begin to summarize and conclude with a couple of slides to kind of wrap this up. So where are we with prevention? I've given you now this big backdrop of the importance of risk factors and markers, what the pathogenesis really is, and how each one contributes. What are the statements? What do our professional societies tell us? Well, the American Heart Association has put together what they call a primary prevention statement as well as a secondary prevention statement. And very interestingly, the European Society of Cardiology has done this as well. And I encourage you to read these. They're very interesting. I actually like the European Society guidelines a lot for several of them because they tend to be a little bit more holistic. They bring everything in, and they're not as cut and dry. And what I would tell you, though, is that these concepts of primary prevention versus secondary prevention, it's a little bit out the window, sort of what I showed you before. It's a continuum. You have to prevent it from childhood, even from planning of a birth, really. You have to prevent it all the way along. It's not just primary as well as secondary prevention. And there's actually a lot of overlap in the guidelines. So the technical definition, primary prevention attempts to prevent the onset of coronary disease in individuals without clinical coronary disease. But we already know that they have atherosclerotic disease in their arteries because that's just the way it is in our modern society. Secondary prevention attempts to prevent the progression of disease in a patient that already has a clinical event. And they typically are much higher risk. So again, I'm just going to refer to the left-hand panel. This is from the AHA guidelines, and I encourage you to read this paper in circulation. Certainly smoking is de rigueur. It's out. It is a major risk factor. You need to stop smoking, and you should use whatever intervention is appropriate. Blood pressure control. Remember, it's a continuum. Lower is better. Certainly 130 over 80, 140 over 90 is our classic, but really you'd certainly like to have the patient have a lower blood pressure in context. If the patient has heart failure and other issues, you don't want to be too low. But ultimately, you certainly would like to reduce your blood pressure, and any incremental benefit you can do there helps significantly in reducing risk. LDL targets. The published target is 100, but as I made the case for you based on high risk, but I would still advise for all risk, you attempt to get that LDL to 70, and attempt to reduce your overall cholesterol, and attempt to raise your HDL as well. I won't go through the details, but they certainly exercise and diet and plant phytosterols are encouraged, and then we move into statin therapy and then additional therapy on top of that. Physical activity. I'll read it for you. They encourage 30 minutes, 7 days a week. I was always told, when should you exercise? Only on the days that you eat. That's really the point. So that's really the point about when you should exercise. Weight management. Clearly important to attempt to maintain a reduced BMI, and the central obesity is really a problem. Diabetes, hemoglobin A1C less than 7%, and you should monitor this in your patients. Now, mixing in this sort of secondary prevention, antiplatelet therapy. Very interestingly, clearly we understand the role of thrombosis. In the European guidelines for primary prevention, they do not recommend platelet therapy. I don't agree with that. I do agree with over 40 considering antiplatelet therapy, certainly over 50 low-dose antiplatelet therapy as well. And then this is more for secondary prevention. The use of ACE inhibitors and beta blockade are also important agents as well. This is a beta blocker. And very interestingly, influenza vaccination. What I'm not going to go through extensively, I have 1 or 2 slides that I'm going to share with you before I end on infection, But what we've learned out of the whole infection paradigm is that influenza vaccination is actually very helpful in reducing risk of cardiovascular disease in the patient. So they actually gave this a 1B recommendation for patients with coronary disease. They should have a flu shot every year. So now I've gone through a lot of things. I want to talk a little bit about what was hot in the last 5 to 10 years, the idea that infection was driving atherosclerosis. So the idea was that an infectious agent, we already talked about diabetes and lipids driving an atheroma formation in an artery, and we've talked about inflammation. Well, we certainly know infection drives inflammation. How about infection being another cause behind all this leading to coronary artery disease? Well, is it plausible? We know that infection leads to an immune response. And in the new immunology, there are these helper T cells, Th1 and Th2. They do different things. Th1 cells drive macrophages, which then drive this inflammatory response. Th2 cells make antibodies, which drives either an immune response or an autoantibody response. Just as an aside, last week I was at a major meeting speaking about the relation of immunology and infection, etc. And I will tell you that I had to review immunology. I will tell the physicians in the audience that I started as an immunologist, then became a cardiologist, and spent some time at the NIH working on these things. Immunology is exploding as a field. I had to re-review the textbook. To everything we knew, we don't know anything. Now it's completely modern immunology. But the other important point is, in the current immunology textbooks, they don't even talk about inflammation. That has become a whole separate topic, and immunology has burgeoned to be such a big thing. So I encourage you, if you're just interested a little bit on this, this is a very exciting area that's kind of exploding. So inflammation is really different than the immune response, yet they talk to each other, but they're components driving atherosclerosis. So there are many ways that an infectious agent could could lead to a problem in the vessel wall. This is from Steve Epstein, who's been a leader in this space. He was at the NIH. It could lead to smooth muscle cell accumulation, turning on of a lot of growth factors, lipid accumulation, endothelial dysfunction, etc. So infection is plausible. The other idea is that there's an echo hypothesis, that if you have one infection in another area, it'll drive a secondary infection. So if you have a lung problem, then a gut problem, all these things add up to driving a problem in the blood vessel. So what's been shown? There have been many infectious agents that have been purported as being contributory to atherosclerosis. Here's direct evidence. Here is an atheroma that they stained for chlamydia, which is a common pathogen in the environment, and they actually see evidence of chlamydia in the lesion. But I will tell you, the quick answer to this is it's not ready for prime time. There have been many studies, small clinical trials, large trials, and even larger trials that looked at antibiotics and vascular disease, which have looked at could we use a little bit of antibiotic therapy to block the progression of atherosclerosis. And the bottom line is from Jeff Anderson, New England Journal, is that all these trials were negative. They really didn't make a difference. But in these trials, they had to take an antibiotic like once a week and all this stuff. So my answer on this is it still remains unknown. And I think that actually there are many organisms that are involved in the pathogenesis of atherosclerosis as yet another risk factor for patients, that there's a pathogen burden, and the significance of the immune response may be more important than the infection. And the issue is in terms of timing. Many of the patients they studied had existing coronary artery disease. If you want to prevent, we want to basically look at how we might manipulate this earlier on in patients sort of as primary prevention. And the one therapy that they tried was to treat chlamydia, which is a very difficult organism to treat. It lives in a privileged space. It's an obligate intracellular organism, and using an antibiotic once a week is not really going to blow it out. So I think that these trials were highly flawed. The final thing I wanted to tell you about is something that I've been collaborating on, and interestingly, it's kind of a hot area, is I've been working with the dental community. And I just came back, I was the speaker for the Society for General Dentistry and the American Dental Association. And what we've coined is this, what we call OBIT, this oral body inflammatory connection, that there's an emerging working hypothesis that oral disease, particularly periodontal disease, may be an associator driver and a pathogenic contributor to systemic disease. And in this relationship is an infection, which then leads to an immune response and inflammation, which is both local, systemic, and in particularly chronic. And this is the idea. If you have poor oral hygiene, it leads to tooth decay, which then can lead to gingival disease and then to periodontal disease, which has a set of hierarchies. This can be graded as well, early disease, but it's this heavy periodontitis, which is associated with bone loss and a chronic recurrent inflammatory process that attempts to drive really atherosclerotic disease. This is what goes on. This is your tooth. This is the gum in the area an infection occurs, but there's many inflammatory and immune response that occurs, and then an inflammatory response that occurs as part of the immune response as well. Now, what's seen in the mouth? The same actors, IL-1, IL-6, IL-8, same things that we see as drivers of coronary artery disease. And this is from the ARIC study, which is a very large study in communities, and what they actually looked as no mild or serious periodontal disease, and there was a fairly linear correlation with intimal medial thickness, a marker of atherosclerosis in patients. And there have been many reviews. This is a recent meta-analysis, 2008, which looked at periodontitis alone or tooth loss. Edentulosum from periodontal disease is a big risk, and clearly there's an increased association with periodontal disease with coronary artery disease. Some exciting things I thought I'd share with you is things that we're working on. This is from an abstract we actually sent to the American Heart Association, so you are embargoed. You can't really talk a lot about this. But this is some things that we sent in. We've done a study in women, postmenopausal women that were at high risk. 113 patients were involved in this trial in multiple medical centers. And what we actually looked at is, could we modify their inflammatory response by using subantimicrobial dose doxycycline, which is an antibiotic, but at a super low dose, it has no antibiotic effect. It's an anti-inflammatory modulator. And what we were able to show is that after 2 years, we reduced CRP by 18% compared to placebo, and we actually raised HDL, and we also dropped MMP9. So I think my point to you is that there are still new risk factors and new aspects of this process that we may ultimately manipulate. Now let me close, and I have to bring this back to wine. So in the periodontal literature very recently, they actually did a study looking at wine consumption and periodontitis. I just made a big case that periodontal disease is a problem. You better go out and brush your teeth. But also wine consumption is very interesting in that as you progressively increase the number of drinks per week, you saw a very nice reduction, a dramatic reduction from a risk ratio of 1 down to 0.24 if you drank several glasses of wine per week. Now, I would say this probably goes a little bit beyond where we might talk about as being safe from a cardiovascular perspective. We could debate that. But certainly, a little here, more was better as far as reducing periodontal disease. So I thought that was kind of interesting. And to really kind of tie this all together, what's very clear in atherosclerotic biology is that there may be many inciting stimuli. They may be endogenous and genetic. They may be exogenous in terms of lifestyle. They may be exogenous like an infection or something else, a chemical agent, an irritant. This leads to an immune response, which leads to inflammation, which then drives the immune response, and on, and this can certainly drive atherosclerotic disease. So I'd like to conclude. I've given you a kind of a whirlwind overview of where we are today, and I took a little liberty to go even beyond my topic to talk a little bit about where we might go as far as other interesting aspects driving atherosclerosis. And I'll tell you that atherosclerotic disease is a very complex disorder driven by multiple factors: genetic, dietary, lifestyle, and environment. And while we understand a lot about the biology of this disease, we still have many aspects that are still unknown to us. But modification of traditional as well as some of the novel risk factors has certainly led to a reduction in mortality and morbidity of these patients. What's incumbent upon us as healthcare professionals is that the best medical practice demands risk stratification, a little more than I think we do. We just ask about it. I think you should use some of these risk assessment tools. I kind of got turned on to them after doing this review. I think they're pretty nice. So a detailed history, the physical lab, etc., and using these tools helps set the patient in the best way we know today. And what we know is that even modest modification of any one of a few risk factors leads to major gains of reduced risk for the patient. And as I just showed you with a little sort of tidbit towards the end, is that novel pathogenic mechanisms continue to be described, like periodontal disease and others, that modification of which may further reduce risk. Thank you very much for your attention.